So good afternoon dear students. So today's topic we have dislocation of shoulder, elbow dislocation and hip dislocation. So these are the major joints which get displaced and knee also. But we will study shoulder dislocation, elbow dislocation and hip dislocation. So in shoulder dislocation, this is the commonest joint in the human body to dislocate. So this is the commonest joint in the body to dislocate. It occurs more commonly in adult. In adult, it's more common and is rare in children. In children, you won't see. Anterior dislocation is much more commoner than posterior dislocation. So anterior dislocation is much more common. Okay. So what is shoulder instability? This is a broad term used for shoulder problem. Any shoulder problem you can tell shoulder instability. So where head of humerus is not stable in the glenoid. So head of humerus is not stable in the glenoid. It has a wide spectrum. It has a wide spectrum from minor instability to a loose shoulder. Minor instability to loose shoulder to frank dislocation. Right? In the former, the patient may present with just pain in the shoulder, minor stability. In minor instability, the patient may just pain in the shoulder, present to pain in the shoulder. So more on using the shoulder. Shoulder जब use करेगा, then they will have pain. Pain occurs due to stretching of capsule. Why pain? Pain because of stretching of the capsule. As the head moves out in some direction without actually dislocating, not dislocating but it moving, then a patient with frank instability may present with abnormal movement of the head of humerus. So frank instability, if there is a clear instability, may present with an abnormal movement of head of humerus. So this could be partial movement, subluxation, which get spontaneously reduced, or a dislocation. The instability may be in one direction, unidirectional, or more direction, bidirectional. So it may be in multiple directions. So anterior, inferior, posterior, where it is called multidirectional instability. Multidirectional instability. So what is the mechanism for this? Why this is happening? A fall on outstretched hand with shoulder abducted and externally rotated. Abducted and externally rotated. This is a common mechanism of injury. Fall on outstretched hand with shoulder abducted and externally rotated. This is the common mechanism of injury. Occasionally, it results from a direct force. Occasionally, it results from a direct force pushing the humeral head out of the glenoid cavity. A posterior dislocation may result from direct blow on the front of shoulder. Direct blow on front of shoulder, driving the head backward. More often, however, posterior dislocation is consequence of an electric shock or elliptiform convulsion. ठीक है? Then we will study pathoanatomy. What is pathoanatomy here? Classification. So classification, dislocation of shoulder may be of the following types. What is the types? Number 1, anterior dislocation. So what is anterior dislocation? In this injury, the head of humerus comes out of the glenoid cavity and lies anteriorly. It may be further classified into 3 types depending on position of the dislocated head. Preglenoid, the head lies in front of glenoid. Preglenoid, the head lies in front of the glenoid. Subcoracoid, the head lies below the coracoid process. Most common type of dislocation is subcoracoid. So most common type is subcoracoid. The head lies below the coracoid process. The most common type of dislocation. Next is subclavicular. The head lies below the clavicle. The head lies below the clavicle. And next is posterior dislocation. Posterior dislocation. So in posterior dislocation, in this injury, head of humerus comes lie to posteriorly behind the glenoid. Posteriorly behind the glenoid. So look at the figure. It's given normal is there, preglenoid, subcoracoid, and third is infraclavicular. Okay, A, B, C. preglenoid, subcoracoid, and infraclavicular. So next is luxatio erecta, luxatio, luxatio erecta is inferior dislocation. So this is a rare type. This is a rare type where head comes to lie in the subglenoid position. Subglenoid position. This is a rare where the head comes to lie in the subglenoid position. So what is pathological change here? Pathological change. The following pathological change occur in the columnar anterior dislocation. Following pathological change occur in columnar anterior dislocation. Anterior dislocation में होगा क्या होगा? नंबर 1 Bankert legine, Bankert legine. Dislocation causes strapping. Dislocation causing strapping of glenoid labrum. Dislocations causing strapping of glenoid labrum along with periosteum, from antero-inferior surface of glenoid and scapular neck. So dislocation causes strapping of glenoid labrum, along with periosteum from antero-inferior surface of glenoid, and scapular neck. Head thus comes to lie in front of scapular neck, in the pouch thereby created. In severe injury, it may be avulsion of piece of bone from antero-inferior glenoid rim. It is called bony Bankert legine. Next, so Bankert legine, as you see, subscapular tendon is there, anterior capsule and rim, anterior capsule and labrum, periosteum, glenoid, posterior capsule and head of humerus. So Bankert legine is there, Hill-Sachs legine is there. Bankert legine is like this, Hill-Sachs legine is this, and evernated rim of soldier is like this. So pathoanatomy of anterior dislocation of soldier. Next is Hill-Sachs legine. So what is Hill-Sachs legine? It is a depression on the head, humeral head. It is depression on the humeral head in its posterolateral quadrant. Posterolateral quadrant. It is a depression on the humeral head in its posterolateral quadrant caused by impingement by anterior. Caused by क्यों होता है? How? Caused by impingement by anterior edge of glenoid on the head as it dislocates. So second is Hill-Sachs legine. Third is rounding off anterior glenoid rim. It's a rounding off the anterior glenoid rim occur in chronic cases as head dislocates repeatedly over it. So there may be there may be associated injury like fracture of greater tuberosity, rotator cuff tear, and chondral damage, cartilage damage. So how you are going to diagnose this kind of cases? So diagnosis: presenting complaint. What is the complaint then? Patients enter the casualty emergency room with his shoulder abducted. Shoulder is abducted away from body, abducted, and elbow supported with opposite hand, दूसरे हाथ से पकड़े हुए आएगा अभी. So there is a history of a fall on outstretched hand. Followed by pain and inability to move the shoulder. There may be a history of similar episodes in the past. Then you are a doctor, so you will do examination. What you will do on examination? The patient keep his arm abducted. The normal round contour of the shoulder joint is lost. So normal contour is round. Okay. So normal round contour of the shoulder joint is lost and it becomes flattened. कैसे हो जाएगा? Flattened हो जाएगा. On a careful inspection, जब आप देखोगे, one may notice fullness below the clavicle. आप देखोगे fullness होगा below the clavicle due to displaced head. So this can be felt by rotating the arm. The following are some of the signs associated with anterior dislocation, mostly of academic significance. So what are the signs? आप डॉक्टर हो तो आप साइन देखोगे. क्या देखोगे? दुगास टेस्ट. दुगाज टेस्ट क्या होता है? इनएबिलिटी टू टच द अपोजिट सोल्जर, पेशेंट इज नॉट एबल टू टच हिज अपोजिट सोल्जर, सो दुगाज टेस्ट फर्स्ट टेस्ट। दूसरा है हैमिल्टन रूलर टेस्ट करेंगे। हैमिल्टन रूलर टेस्ट ये क्या होता है? बिकॉज ऑफ फ्लैटनिंग ऑफ द सोल्जर इट इज पॉसिबल टू प्लेस अ रूलर ऑन द लैटरल साइड ऑफ द आर्म। So because of flattening of the shoulder, it is possible to place a ruler on the lateral side of the arm. So this touches the acromion and lateral condyle of the humerus simultaneously. The diagnosis is easily confirmed on anteroposterior X-ray of the shoulder, AP view of the shoulder. And axillary view is sometimes needed. So posterior dislocation usually occurs following a convulsion हुआ तो होगा. There are a few signs and symptoms. So X-ray of shoulder AP view showing anterior dislocation of the shoulder. The injury is often missed even on X-ray. X-ray में नहीं दिख सकता है. A clinical examination eliciting loss of external rotation and external rotation नहीं कर पा रहा है, and careful look at the X-ray may help diagnose these cases. ठीक है, तो CT scan may be diagnostic. So what is the treatment now? So treatment of acute dislocation is reduction under sedation or general anesthesia. So treatment of acute dislocation is reduction under sedation or general anesthesia, followed by immobilization of shoulder in a arm chest bandage for 3 weeks. Arm chest bandage for how many weeks? 3 weeks. Okay, after the bandage is removed, जब remove कर देंगे, the shoulder exercises are begun. Okay, so अब हमें सीखने वाली बात है टेक्निक ऑफ रिडक्शन ऑफ शोल्डर को रिडक्शन करने की टेक्निक क्या है? तो नंबर 1 है कोचर मैन्यूवर कहते हैं. कोचर मैन्यूवर में क्या होता है? दिस इज अ मोस्ट कॉमनली यूज्ड मेथड. द स्टेप्स आर एज फॉलोज. नंबर 1, पहले क्या करेंगे? ट्रैक्शन देंगे. ट्रैक्शन माने तानना. ट्रैक्शन विद द एल्बो फ्लेक्स्ड टू राइट एंगल. स्टेडी ट्रैक्शन इज अप्लाइड अलोंग लॉन्ग एक्सिस ऑफ ह्यूमरस. So traction with elbow flexed to right angle. Steady traction is applied along the long axis of humerus. Number 1. Second is external rotation. The arm is rotated externally. External rotation, and then adduction. The externally rotated arm is adducted by carrying the elbow across body towards the midline. Okay, and then internal rotation. The arm rotated internally so that hand falls across to the opposite shoulder. So to remember the steps of reduction, remember TEAI: traction, external rotation, adduction and internal rotation. ठीक है. Now so we will have another method that is called Hippocrates method. In this method, the surgeon apply a firm and steady pull on semi-abducted arm, not a fully abducted, semi-abducted. Okay. In this method, the surgeon applies a firm and steady pull on the semi-abducted arm. So he keep his foot in the axilla against the chest wall. The head of humerus is levered back into position using the foot as a fulcrum. A fracture of the greater tuberosity, often associated with anterior dislocation, usually comes back to its position as the head is reduced and need no specific treatment. Okay. Now ये सब किया आपने, then the patient even have chances of complications. So what is the complication now? अर्ली कॉम्प्लिकेशन एंड लेट कॉम्प्लिकेशन. सो शुरू में क्या कॉम्प्लिकेशन होगा और बाद में क्या होगा? सो कॉम्प्लिकेशन कैन बी डिवाइडेड इनटू अर्ली एंड लेट. सो अर्ली कॉम्प्लिकेशन, इंजरी टू एक्सिलरी नर्व डैमेज होगा, मे अकर रिजल्टिंग इन पैरालिसिस ऑफ डेल्टोइड मसल. So injury to axillary nerve may occur resulting in paralysis of deltoid muscle with a small area of anesthesia, छोटा सा area of anesthesia over the lateral aspect of the shoulder. So injury to axillary nerve may occur resulting in paralysis of deltoid muscle with a small area of anesthesia over the lateral aspect of shoulder. The diagnosis is confirmed by asking the patient. The diagnosis कैसे confirm है? The diagnosis is confirmed by asking the patient to try to abduct the shoulder. Abduct करिए, नहीं कर पाएगा. Though shoulder abduction may not be possible because of pain, one can feel the absence of contraction of deltoid. One can feel the absence of contraction of deltoid. The treatment क्या है इसका? Treatment है conservative, prognosis is good. Treatment is conservative, prognosis is good. Then late complication delay होके आया तो क्या होगा? The shoulder is commonest joint to undergo recurrent dislocation. बार बार हो जा रहा है. So this results from following causes. What are the causes then? Anatomically unstable joint. और दूसरा example in Marfan syndrome. And second is inadequate healing after the first dislocation. First dislocation के बाद में अच्छे से हील नहीं हुआ. और एन इपिलेप्टिक पेशेंट, और इपिलेप्टिक पेशेंट है, मिर्गी का दौरा आ रहा है तो उसको ऐसा हो. देन व्हाट इज द ट्रीटमेंट नाउ? Treatment: if the disability is troublesome, operation is required. The following operations may be considered. ये 3 ऑपरेशन करेंगे. क्या करेंगे? नंबर 1 पट्टी प्लाट कहते हैं. पट्टी प्लाट ऑपरेशन. डबल ब्रेस्टिंग ऑफ सब स्कैपुलर टेंडन होता है यहाँ पे, सब स्कैपुलरिस, उसको डबल ब्रेस्टिंग करेंगे. डबल ब्रेस्टिंग ऑफ द subscapularis tendon is performed in order to prevent external rotation and abduction. In order to prevent, रोकने के लिए external rotation and abduction, thereby preventing recurrences. So by this way you are preventing the recurrences. डबल ब्रेस्टिंग करेंगे, कट लगा के उसको फिर से सुचर करेंगे तो distance will be shorter ना. तो because of that external rotation and abduction is not happening. Next is Bankert operation. पट्टी प्लाट ऑपरेशन समझ में आ गया. देन इज बैंकट ऑपरेशन में क्या होता है? द ग्लिनोइड लैब्रम एंड कैप्सूल. द ग्लिनोइड लैब्रम एंड कैप्सूल आर रीअटैच्ड टू द फ्रंट ऑफ ग्लिनोइड रिम. ये ग्लिनोइड का रिम है, तो हियर ग्लिनोइड रिम के आगे ग्लिनोइड लैब्रम और कैप्सूल को रीअटैच कर देंगे हम लोग टू द फ्रंट ऑफ ग्लिनोइड रिम. So this is technically demanding procedure but has to be simpler with use of special fixation devices called anchor. जो लगाएंगे उसको कहते हैं anchor. उसके बाद है ब्रिस्टो ऑपरेशन में क्या होता है? ब्रिस्टो ऑपरेशन में in this operation the coracoid process along with its attached muscle, ब्रिस्टो लटार्जेट जो कहते हैं उसमें. तो ब्रिस्टो ऑपरेशन में in this operation the coracoid process along with attached muscle is osteotomized at its base and fixed to lower half of anterior margin. ठीक है. In this operation, ब्रिस्टो ऑपरेशन में in this operation the coracoid process along with attached muscle is osteotomized at its base and fixed to lower half of anterior margin of glenoid. The muscle attached to coracoid provide a dynamic anterior support to the head of the humerus. उसके बाद यही फोटो आपको दिखा रहे हैं कि आर्थ्रोस्कोपिक रिपेयर ऑफ शोल्डर डिसलोकेशन में बैंकट लेजाइन है, वहाँ पे दिख रहे हैं. तो आर्थ्रोस्कोपिक रिपेयर विथ एंकर लेकर के रिपेयर किया. स्कार ऑफ आर्थ्रोस्कोपिक रिपेयर, स्कार देखिए, स्कार ऑफ ओपन रिपेयर. सो आर्थ्रोस्कोपिक रिपेयर ऑफ शोल्डर जॉइंट. नेक्स्ट इज आर्थ्रोस्कोपिक बैंकट रिपेयर कैसे करेंगे? आर्थ्रोस्कोपिकली with the development of arthroscopic technique it has become possible to stabilize a recurrently unstable shoulder arthroscopically. Initially it was considered suitable for cases where number of dislocation has been less than 5, but with present day arthroscopic technique it is possible to stabilize most unstable shoulder arthroscopically. Apart from being a more cosmetic option, the rehabilitation after arthroscopic repair is faster and better. So it is technically demanding operation, and the suture anchor and the anchor suture used for repair are expensive. So this technique is available only in selected center. ठीक है. उसके बाद में आप लोग एब्सेंट हुए तो ये नहीं तो फ्रैक्चर ऑफ सर्जिकल नेक ऑफ ह्यूमरस, फ्रैक्चर ऑफ ग्रेटर tuberosity ऑफ ह्यूमरस, फ्रैक्चर ऑफ शाफ्ट ऑफ ह्यूमरस. So injury around the elbow. ये हम लोग अगले क्लास में पढ़ेंगे. सुप्राकोंडलर फ्रैक्चर ऑफ ह्यूमरस, lateral fracture of lateral condyle of humerus, intercondylar fracture of humerus, fracture of medial epicondyle of humerus, pulled elbow 2 to 5 years में ज़्यादा होता है pulled elbow, dislocation of elbow joint. So dislocation of elbow joint पढ़ते हैं. So posterior elbow joint के लिए क्या होता है, anterior की posterior dislocation is the commonest type of elbow dislocation. So posterior dislocation is the commonest type of elbow dislocation. Other dislocation are posteromedial, posterolateral and divergent. So what is divergent? A dislocation of elbow where radius and ulna displaces laterally and medially respectively, that is diverge. So dislocation of elbow joint, posterior dislocation is the commonest type of elbow dislocation. Other dislocation are posteromedial, posterolateral and divergent. It may be associated with fracture of epicondyle, fracture of head of radius, or fracture of the coronoid process of ulna, Clinically, there is severe pain. Clinically, there is severe pain at the elbow. So it may बोल रहा है कि it may be associated with fracture of medial epicondyle भी हो सकता है इसके साथ, फ्रैक्चर ऑफ हेड ऑफ रेडियस हो सकता है, फ्रैक्चर ऑफ कोरोनॉइड प्रोसेस ऑफ अल्ना भी हो सकता है. Clinically, there is severe pain at the elbow. So triceps tendon stands prominent. Clinically, there is severe pain at the elbow. Triceps tendon stands prominent. Prominent दिख रहेगा. Bowstring कहते हैं, bowstring of triceps. Triceps tendon stands prominent. Bowstring of triceps. Bowstring, B-O-W, stringing. Bowstringing of triceps. 3 bony point relationship is reversed. 3 point bony relationship is reverse हो जाएगा. There is often an associated median nerve palsy. हो जाएगा इसमें. Diagnosis is easily confirmed on X-ray करके. Treatment, so it is by reduction under anesthesia. Followed by immobilization in an above elbow plaster slab for 3 weeks. Above elbow plaster slab for how many days? 3 weeks. 1, 2, 3. 3 weeks. So elbow stiffness and myositis. Are common complications, and pulled elbow is common in 2 to 5 years of age. Then fracture of olecranon, fracture of head of radius, fracture of neck of radius, fracture of capitulum, forearm and wrist, fracture of forearm bones, Monteggia fracture, upper third of ulna with dislocation of head of radius. Fracture of upper third of ulna with dislocation of radial head. Glacier fracture dislocation, Colles fracture, Dinner fork deformity. So for Colles, counter traction and traction, then correction of dorsal tilt and correction of radial tilt. So palmar flexion and ulnar deviation, palmar flexion and ulnar deviation में रखेंगे. Then a Smith fracture. A Smith fracture is reverse of Colles. It's uncommon, seen in adult and in elderly people. Importance lies in differentiating the common or Colles fracture which occurs at the same site. Then Barton fracture. Barton fracture, intra-articular fracture of distal radius. Intra-articular Barton, anterior, posterior. So volar Barton, dorsal. Scaphoid fracture. Anatomical snowbox tenderness ना. तो ऑब्लिक व्यू ऑफ रिस्ट करेंगे. 3 to 4 month स्कैफोइड कास्ट पे रखना चाहिए. 3 to 4 month. All such cases clinical scaphoid fracture should be treated scaphoid cast for 2 weeks. Repeated. Immobilize the hand. ठीक है. वास्कुलर नेक्रोसिस हो जाएगा. डिलेट नॉन यूनियन. रिस्ट ऑस्टियोआर्थराइटिस, लूनेट डिसलोकेशन. उसके बाद में हैंड इंजरी में आप देखोगे बेनेट फ्रैक्चर डिसलोकेशन, इंट्रा-आर्टिकुलर फ्रैक्चर ऑफ बेस ऑफ फर्स्ट मेटाकार्पल विथ सबलक्सेशन और डिसलोकेशन ऑफ मेटाकार्पल. सो बेनेट फ्रैक्चर डिसलोकेशन इज oblique intra-articular fracture of the base of first metacarpal with subluxation or dislocation of metacarpal. So K वायर से फिक्स करेंगे. ओपन रिडक्शन, इंटरनल फिक्सेशन. रोनाल्डो, कंप्लीट आर्टिकुलर T और Y सेपरेट फ्रैक्चर ऑफ फर्स्ट मेटाकार्पल. परफेक्ट रिडक्शन इज नॉट इम्पोर्टेंट एज इन बेनेट फ्रैक्चर. ट्रीटमेंट इज बाय एक्यूरेट रिडक्शन एंड फिक्सेशन विथ K वायर and immobilization in thumb spica for 3 weeks. Fracture of metacarpal, displaced mallet finger, baseball finger results from sudden passive flexion of distal interphalangeal joint so that extensor tendon of DIP joint is avulsed from its insertion at the base of distal phalanx. Sometimes it takes a fragment of it. Clinically, distal phalanx is slight flexion. Treatment is by immobilizing the DIP joint in hyperextension with the help of an aluminum splint or plaster. So fracture of the phalanges, then dislocation of metacarpophalangeal joint, amputation of finger, principle of treatment. Every effort should be made to save as much as length of thumb is possible. Amputation in children more conservative. Fingertip amputation need reconstruction in such way that full thickness skin cover the tip. Amputation at the level of distal phalanx. Reimplantation is not possible. Replantation is not performed in the elderly person. Tendon injury of the hand. So testing like this method of testing flexor tendon. So for testing flexor digitorum profundus and flexor digitorum superficialis like this. Okay, and for this the flexor digitorum profundus. Cross injury of the hand. Cluster slab, James position, collateral ligament lax, collateral ligament tight. इसी के साथ इसका टॉपिक ख़त्म होता है और इसमें हम लोग देखेंगे सैक्रल प्रोमोन्टरी होता है, सिंथेसिस प्यूबिस होता है, प्यूबिक क्रेस्ट होता है, अल्ला ऑफ सैक्रम, सैक्रल प्रोमोन्टरी, आर्कुएट लाइन ऑफ इलियक बोन, प्यूबिक क्रेस्ट, प्यूबिक सिंथेसिस. So anteriorly pubic symphysis, posteriorly anterosacroiliac ligament, posterosacroiliac ligament, sacrum, iliac bone. So transverse section through pelvic ring. Classification. So pelvis के लिए टाइप A स्टेबल, उसमें भी A1 A2, टाइप B रोटेशनल अनस्टेबल, वर्टिकली स्टेबल. So B1 open book type, टाइप C रोटेशनली एंड वर्टिकली अनस्टेबल, C1 unilateral, C2 bilateral. So एवं प्रकार से है. तो आज का हमारा टॉपिक है सिर्फ So let's come. This one is the last topic. So dislocation of hip. So classification, there are three main type of dislocation of the hip. Posterior dislocation, the commonest. Second is anterior dislocation, and third is central fracture dislocation. Central fracture dislocation. So तीन है: posterior dislocation, commonest, anterior dislocation, central fracture dislocation. All of these may be associated with fracture of lip of the acetabulum. So posterior dislocation of the hip. The head of femur is pushed out of the acetabulum posteriorly. The head of femur is pushed out of the acetabulum posteriorly, पीछे. In about 50% of cases, it is associated with chip fracture of the posterior lip of acetabulum. Chip fracture of posterior lip of acetabulum, in which case it is called fracture dislocation. And mechanism of injury, what is the mechanism of injury here? The injury is sustained by violence. Injury is sustained by violence directed along shaft of femur. Violence directed along shaft of femur with the hip flexed. It requires a moderately severe force to dislocate a hip. As often occur in motor accident. So the occupant of the car is thrown forward, and his knee strike against the dashboard. The force is transmitted off the femoral shaft, resulting in posterior dislocation of hip. It is therefore also known as dashboard injury. So diagnosis क्या होगा? Clinical feature में देखेंगे. An ipsilateral posterior dislocation of hip, isolated, खाली सिर्फ हुआ है. Posterior dislocation of hip is easy to diagnose. The patients present with history of severe trauma, followed by pain, swelling, and deformity. So what is deformity here? Flexion, adduction, and internal rotation. Flexion, adduction, and internal rotation. So this is associated with shortening of leg. One may be able to feel the head of femur in the gluteal region. The injury is sometimes missed, especially when associated with other more obvious injury. The injury is sometimes missed, especially when associated with other more obvious injuries such as fracture of shaft of femur. So it may go unnoticed in an unconscious patient. The injury is sometimes missed, especially when associated with other more obvious injuries such as fracture of shaft of femur. It may go unnoticed in an unconscious patient. So it is wise to X-ray the pelvis in all patients with fracture of femur to avoid this mistake. So what is radiological feature here? The femoral head is out of acetabulum. The thigh is internally rotated, so that lesser trochanter is not seen. The femoral head is out of acetabulum, thigh is internally rotated so that the lesser trochanter is not seen. Central line is broken. One must look at One must look for any bony chip from posterior lip of acetabulum. One must look for any bony chip. One must look for any bony chip from the posterior lip of acetabulum, posterior lip of the acetabulum, or from the head. A comparison from the opposite normal side may be useful. A comparison from opposite normal side. One must look for any bone chip from posterior lip of acetabulum or from head. A comparison from opposite normal side may be useful. CT scan may be necessary in cases where associated fracture is suspected. So how we will do reduction? So treatment is reduction of dislocated hip in an emergency, since longer the head remains out, more the chances of it becoming avascular. In most cases, it is possible to reduce the hip by manipulation under general anesthesia. In most cases, it is possible to reduce the hip by manipulation under general anesthesia. The chief fracture of acetabulum, if present, usually falls in place as the head is reduced. Open reduction may be required in cases where closed reduction fail, usually in those presenting late. Second, if there is intra-articular loose fragment, not allowing acute reduction, Third is, if the acetabular fragment is large and is from the weight bearing part of acetabulum. If the acetabular fragment is large and is from the weight bearing part of acetabulum, such a fragment make the hip unstable. If the acetabular fragment is large and is from weight bearing part of the acetabulum, such a fragment make the hip unstable. टेक्निक ऑफ क्लोज रिडक्शन कैसा है? कैसे क्लोज रिडक्शन करेंगे? द पेशेंट इज एनेस्थेटाइज्ड एंड प्लेस्ड सुपाइन ऑन द फ्लोर. एन असिस्टेंट ग्रास्प्स द पेल्विस फॉर्म. द सर्जन फ्लेक्सेस द हिप एंड नी एट राइट एंगल. सो ये क्या है? इमेजिनरी सेमी सर्कुलर लाइन ज्वाइनिंग मीडियल कॉर्टेक्स ऑफ femoral neck to lower border of superior pubic ramus. So technique of closed reduction क्या हुआ? The patient is anesthetized and placed supine on the floor. Assistant grasps the pelvis firmly. The surgeon flexes the hip and knee at right angle. Technique of reduction of hip dislocation, and exert an axial pull. Usually one hear a sound of reduction, which is become possible to move the hip freely in all directions. After which it becomes possible to move the hip freely in all directions. The leg is kept in slight traction with the hip abducted. Abducted for 3 weeks. After this, hip mobilization exercises are initiated. So इसमें complication होता है. क्या complication होगा? Injury to sciatic nerve. The sciatic nerve lies behind the posterior wall of acetabulum, so therefore it may be damaged in posterior dislocation of hip. More so if the dislocation is associated with a large bony fragment from the posterior lip of acetabulum. Treatment is injury is a neuropraxia in most cases and recover spontaneously. In cases where fragment of posterior lip is not reduced by closed reduction, open reduction of fracture and nerve exploration may be required. If the sciatic nerve is severely damaged at this level, prognosis is poor. Avascular necrosis of femoral head in some 15 to 20%, मतलब 80% को नहीं होता, 20% को of cases dislocation, the femoral head undergo avascular necrosis. The change of avascular necrosis appear on X-ray generally 1 to 2 years after injury, not right now. Avascular head appears dense. Avascular head कैसे दिखेगा? Appear dense and gradually collapse wholly or in part. The patient complain of pain in the hip after seemingly painless period. Painless period के बाद में pain होना followed by treatment for a dislocated hip. Over a period of few years, change of osteoarthritis become apparent clinically and radiologically. So such cases eventually need hip replacement. And third complication is osteoarthritis. So this is a late complication of hip dislocation occurring a few to many years after the injury. The underlying causes may be avascular deformed head or an incongruous acetabulum and femoral head. The treatment is initially conservative. In some cases, an operation may be necessary. Commonly, a total hip replacement is required. And fourth complication is myositis ossificans. So, this occurs a few weeks to months after injury. The patient complains of persistent pain and stiffness of hip. X-ray show mass of fluffy new bone around the hip. So it is particularly common in patients with head injury. Treatment is rest and analgesic. So this occurs in a few weeks to months after injury. Patients complain of persistent pain and stiffness of the elbow. X-rays show a mass of fluffy new bone around the hip. It is particularly common in patients with head injury. Treatment is rest and analgesic. Rest करेंगे, analgesic. So anterior dislocation of hip. So this is a rare injury, usually sustained when the legs are forcibly abducted and externally rotated. So this is rare injury, usually sustained when the legs are forcibly abducted and externally rotated. So this may occur in a fall from tree, पेड़ से गिर गया, where the foot get stuck and hip abduct excessively, or in a road accident. Hip abducted excessively on a road accident. Clinically, the limb is an attitude of external rotation. There may be true lengthening with the head palpable in the groin. So treatment and complications are similar to that of posterior dislocation. And last is central fracture dislocation of hip. So in this common injury, the femoral head is driven through the medial wall of the acetabulum. So in this common injury, central fracture dislocation of hip, in this common injury, the femoral head is driven through the medial wall of the acetabulum towards the pelvic cavity. In this common injury, central fracture dislocation of hip, in this common injury, the femoral head is driven through the medial wall of the acetabulum towards the pelvis cavity. The displacement of head varies from the minimal to as much as the whole head lies inside the pelvis. So joint stiffness and osteoarthritis are inevitable. Therefore, the aim of treatment in these cases is to achieve as congruous an articular surface as possible. For this, skeletal traction is applied distally and laterally. If the X-ray of AP showing central fracture dislocation, so the fragment fall in place. So if the fragment fall in place and reasonably reconstitute the articular margin, the traction is continued for 8 to 12 weeks. Fragment fall in place and reasonably reconstitute the articular margin, traction is continued for 8 to 12 weeks, माने 2 महीना से 3 महीना तक. In some young patients in whom the fragment do not fall back in place by traction, surgical reconstruction of acetabular floor may be necessary. So complication is hip stiffness, hip jam हो जाएगा, stiff हो जाएगा, myositis हो जाएगा, osteoarthritis are common complications of this injury.